Surgery degree with second-class honors and Master of Science in Operative Dentistry from Mahidol University. And she is also a diplomat of the Thai Board of Operative Dentistry. Her lecture today is titled Pathways to Perfection, the next generation of direct and indirect veneers. Please warmly welcome Dr. Munin Chaichalothorn with a round of applause.
Good evening, everyone. I'm Dr. Munin Chaichalothorn from Mahidol University. First of all, I would like to express my thanks to Prince of Songkhla University, especially Dr. Jilayu Leung Lung Som, for the kind invitation and the opportunity to be part of this wonderful event, IDCMR 2025. And today we're gonna use about 45 minutes, and just about that's the time that we have. Okay, go through this topic together, covering both direct and indirect veneers. And I'll be sharing the key insights and practical points that you can adapt and modify to your clinical work. And I have to go through things a little bit faster today. Our time is quite limited and there's a lot of things that I want to share with you. So I hope that's okay to everyone. Alright? Okay, when we talk about pathways to perfection, I think of a journey that each veneer takes. From the very first moment I meet my patient to the final smile that we create together. And each case is a story, a process that filled with the planning, precision, and passion. And every step along that journey brings us together close to the perfection. And when we talk about pathways to perfection, when we looked closer to the two types of the veneers, the direct composite veneers and indirect ceramic veneers, we quickly realized that they follow different pathways. And each has its own details and challenges and decision points. And we will walk through those steps together from planning to finishing, so you can clearly see how the path to perfection shifts depending on the material and the technique that you use. Let's start with the direct composite veneers and explore how we can achieve excellence through a minimally invasive approach. When we talk about the pathways to perfection in direct composite veneers, before we dive into the step, I would like to invite everyone to take a moment and think back to the restoration that we gave to our patient. Of course, we all want them last as long as possible. But the truth is, nothing lasts forever, right? So one day failure will happen. And as a clinician, what truly matters is that we understand why it failed. So there was a research review that analyzed both retrospective and prospective studies on direct restoration. It revealed that direct anterior restoration showed 5 to 10 years survival rate, ranging from 77% to 97%. And interestingly, the main causes of failure were mostly aesthetic reasons, such as color mismatch and marginal discoloration, and along with the fractures that often relate to parafunctional habits. And that's why we have to talk about the pathways to make it more durable. Let's dive into the first step on our pathway, the design. And even though we are working with a direct composite veneer, this step is still essential. The design can be done in a conventional way like this, using the wax model, or maybe a digital way depending on your workflow. And for direct composite veneers, the goal for this step is to think about and understand the final outcome that we want to achieve. And from this design, we can then fabricate a palatal silicone index that will guide us throughout the restorative process. And then, from our design, we can evaluate the available space for the restoration. And based on that space, I usually consider two types of approaches. The first one is multi-translucent technique, and another one is mono-translucency technique. And each technique has its own character and indication depending on how much the space we have for reproducing the natural optical layers of the tooth. already know, the natural tooth structure is composed of enamel and dentine, and these two components interact with light very differently. Enamel is highly mineralized, which gives translucent appearance to itself, but dentine is more organic and therefore more opaque, creating the unique contrast, especially at the incisal edge, that we recognize as a natural tooth. When our design provides enough space for the restoration, we can perform a multi-translucency layering technique by using the materials with different optical properties to recreate the natural contrast of a tooth at the incisal edge. And we start by building the palatal and proximal wall with the enamel-like material for the translucency. And then follow with the dentine layer that provides more opacity. And in some cases, we can also add the effect materials or characterization such as staining. And before we finish with the final enamel layer to complete the natural outcome. And if you don't have enough space, and for example, in the case that maybe we only perform an enamel resurfacing or don't add any incisal length longer. So here we have to go with the mono-translucency technique. And the next step is bringing our design to life, the fabrication of the restoration. Using the hand sculpting technique, especially with the multi-translucency technique, we can transform a plan into a restoration that looks and feels like a natural teeth. And let me show you an example in the next slide. Here is a case where we use direct composite veneer as part of smile reconstruction. The patient was a retired teacher who wanted to regain a confident smile. And she had malaligned teeth here and a lot of defective composite fillings. Ideally, we should start with the orthodontic treatment first, but the patient declined to follow that plan. So we have to proceed with an alternative approach. In this case, using direct veneers to restore her smile. And I start by taking the impression and create a wax-up model, which was then used to fabricate the palatal silicone index for the restoration. And next, I removed the old defective restoration and began the layering technique, starting with an enamel shape for the palatal and proximal wall. And then I add a dentine shape to shape the dentine lobe. And now we move on to the final enamel layer. If all the steps are done correctly, after the polishing, the restoration will display a beautiful contrast of translucency and opacity at the incisal edge, imitating the natural tooth. And please excuse the bleeding here because it was taken immediately after polishing. And here is the 6-month follow-up. So it looks very natural, and my patient was very happy and satisfied with her new smile. And as I mentioned earlier, in case that we have limited space, we turn to the mono-translucency because there isn't enough space for layering. So we need to rely on a single shade. And this patient came to me wanting to brighten her teeth, and she had tried bleaching before, but wasn't happy with the result. So she still wants her teeth whiter and a little bit longer. And after discussing the options, we decided together to proceed with the composite veneers. And because the available space was limited, I chose for the mono-translucency technique in this case, but I still fabricated with the layering technique, starting with the palatal layer first to form the foundation. And next, I built the proximal wall to create the outline of the tooth. Then I add the labial increment to the final layer. And one more thing that really makes your veneer look beautiful is especially important for hand sculpting composite veneers is polishing step. It's actually the final step in our pathways. So stay tuned for that part. I will walk you through it later. And after completing the layering, I polished the composite veneers until they achieve a glossy, natural-looking surface. And this is from the start. Here you can see the 6-month follow-up result. Nowadays, we also have another techniques for fabricating composite veneers, the injection molding technique. We have to start with the design first, either using a wax-up or a digital 3D printed model. And from this, we create a clear silicone mold to replicate all details precisely. And then we place the clear silicone onto the tooth and use it to fabricate the injectable veneer with a highly filled flowable composite. And interestingly, this isn't a true new technique because everything new is just forgotten old. The injection molding technique was actually proposed back in the 1980s when it was used to fabricate restorations in a semi-direct way. But today we have adapted this approach to be used directly. And the injection molding technique brings several benefits to us. It is highly predictable, and especially with the digital design, it allows repeatable results. And it is simple to execute, and it is almost more affordable when compared with the ceramic veneers. That's all benefits, making it as one of a practical choice for the composite veneer. And let me share a case to illustrate this technique. The patient traveled from abroad, so she came to me for the ceramic veneer at first, and she had already tried bleaching, but wasn't satisfied with the result, and still wanted her teeth look brighter. And because of the limitation about the treatment time, so we decided to go for the injectable veneer, and she will return back again next year for the ceramic veneer. And as I looked at her smile, I immediately noticed that the mouth alignment in the upper front teeth with the right central incisor here being especially prominent. And I initially recommend orthodontic treatment and show her a digital smile design, and she also denied. But one of the great benefits of using a digital design is that it actually helps with the communication. For example, in this case, we could show the patient exactly what the future outcome would look like, and making it much easier for her to understand and participate in the treatment planning. And that design clearly demonstrates that we would need to reduce the upper right central incisor, especially at the distal part here. And first, I can use the color indicator that shown in the digital design to identify exactly which area of the tooth that need to be prepared, or which part that it is added restoration. So here is the initial design, and I later moved the design more buccally to make the final restoration more additive and minimize the amount of tooth reduction required. And then we print out the plastic model and made the clear silicone model with this design. And the first step in preparation was to carefully grind down at the distal surface of the upper right central incisor and create space for the injectable veneer but keeping much natural to stutter as possible. And then I carefully place PTFE every other tooth, isolating them one by one. And next, I follow by adhesive application. Then I use a silicone mold to fabricate the final veneers. And after complete the first round of injection, you often see the composite overflow on the adjacent teeth. It's important to remove this carefully before moving on to the next round to inject the next veneer, and to make sure for clean margins and precise proximal contour. And then I repeat the process of isolation the teeth, pressing the TFE tape every other tooth again, and again apply adhesive. and perform the injection for the second round of veneers. And finally, I complete the restoration with finishing and polishing. Here is the outcome that reveals a beautiful glossy surface and complete the smile transformation for this case. And she plans to return next year to replace these with the ceramic veneer. And with the digital design, I can follow the same design when she comes back. And personally, I often use the injectable veneer as some like a long-term intermediate restoration, especially for patients who are considering the ceramic veneer but maybe not yet ready or maybe have some limitations. So this kind of restoration allow my patient to experience the new smile first and decide later whether they want to move forward with the ceramic veneer or not. But one important thing is to keep in mind that choice of flowable composite is very important. Not every flowable material can be used for this technique. Most conventional flowable composite contain a higher resin content and lower filler load. So they are weaker and more prone to color staining or poor color stability over the time. So it's always better to go with a highly filled flowable composite for this kind of the restoration. So there is actually a systematic review that compare highly filled flowable composite with conventional nano-hybrid composite. And interestingly, their overall clinical performance was quite comparable. And no significant difference in the color stability, surface roughness, and marginal adaptation. But micro hardness, fracture strength, and wear resistance is still controversial. So that means this highly filled flowable can actually be an option for anterior restoration. But in patients with severe tooth wear or having a heavy parafunction habit, this material should be used with caution and maybe even avoided. Personally, I still prefer a hand sculpt technique as the way to do composite veneer. And now we move to the final step, finishing. This is very important step because if it's not done correctly, the veneer can end up look like a chiclet or maybe a piano keys like this. So there is a published study that provides a checklist for finishing and polishing composite veneers. This checklist really helps us control the shape effectively. But if you'd like to read more about it, I've included a reference at the lower part of the slide here because we have limited time. But in fact, you still need to follow the proper polishing step to achieve that final gloss. To perform a finishing and polishing correctly, we need to understand our polishing instruments, as there are many options on the market and they often differ between the clinics. Have you ever spent so much time polishing a restoration and going back and forth and trying every polishing tool in the clinic and it still doesn't shine? The reason might be that you chose the wrong instrument or use the wrong sequence. Every clinic has different tools and it's easy to get lost in the option. Today I'm going to show you the correct sequence for polishing. For this slide, I work together with Dr. Nantipon Wongviwat, who is my colleague, and we gather and arrange the polishing instruments from different brands and systems, and all in one place for you to understand their basic size and their material and which step you are in, so that everyone can use this in practice. Polishing always goes from coarse reduction, contouring, finishing, and polishing, from coarse to fine. And of course, in our life, in our practice, we often combine polishers from different systems. But if we don't understand their sequence correctly, we might end up polishing back and forth. For example, moving from the yellow band burr here, which in the finishing step, and then you go back to the enhanced polisher here, that belongs to the contouring step. And that can make your surface rougher instead of smoother. So if you are using multiple systems, don't forget to check this first. And someone asked me, what is your polishing system that you use? The thing is, I use as the same system as everyone, but I always follow the sequence. So please remember, sequence is always the key. And you may heard about the trend that use surface coating agents just to make the composite veneer glossy. Some suggest using a dental adhesive, others recommend a modeling liquid, or even a resin coating. But the question is, do these coating materials really improve the gloss and longevity of the composite veneers? There is study that testing various coating agents, including the hydrophobic resin, universal bonding, composite wetting resin, modeling resin, and the resin coating to elevate their effect on color stability and surface roughness of composite veneers. And the results show that none of the coating agents were able to improve the color stability of nano-composite veneers. Moreover, most coating agents actually increase surface roughness even before brushing. So I'm not recommend to use this kind of material for coating composite veneers. But I like to use these materials for coating temporary veneers. And I will explain this later when we go to the ceramic veneer section. So the best approach is to carefully polish the composite to achieve a durable high gloss surface, rather than relying on a coating agent. So please keep in mind about the sequence of polishing step. And this is wrap up our section on direct composite veneer. Complete pathway to perfection from design to polishing. Now we will shift our focus from direct composite veneer to indirect ceramic veneer. And let's look at different pathways to perfection. And yes, we still start with the first step, design. The conventional method is to create a wax-up model. Traditionally, we make a wax-up model based on the facial and tooth proportions derived from photograph, confirming that the final veneers correspond with the facial of the patient and facial features. However, mistakes can easily happen because the angle that we take a photo can distort our perception, causing us to get the wrong idea about the tooth plane and proportion during the design process. Nowadays, we have a digital design, which allows us to overlap the patient face, here, patient face photo, right onto the design. And this makes the design process much more accurate than traditional methods. And we can also evaluate thickness of the restoration when we assessing the tooth width and tooth length. Even though digital design is more accurate than a conventional way, it is still 2D representation, and when we merge it onto the photos, some error can still occur. Today we have 3D facial scan technology that allow us to capture the patient face in 3D and superimpose it right onto the intraoral scan model and CT scan. And there are two systems commonly used. The first one is Medismile. The second one is RayFace, which significantly improves the accuracy of our veneer design. And at Mahidol University, we have already implement this technology. And as you have seen from the previous session by Dr. Shashwin and Dr. Waraya, and also from a topic from Dr. Chai Mongkol, there are so many new technologies and digital tools that can support us in the design process. And actually there are even more possibilities beyond what we have talked about today. And all of these tools give us a new way to plan and to communicate better with our patient. And then we can create the 3D printed models to prepare for the next step in the workflow. And the next step is tooth preparation, which I consider it as the most important step. That's why I add a heart icon here. It represents the key to success in the next few minutes from now. I will walk you through why this step is so crucial and describe how it forms the foundation of a perfect restoration. In the past, veneer preparation was often prepped from the present, meaning that the preparation was driven by the existing tooth surface, which can easily cause dentine exposure. But if you look at the natural enamel thickness, especially at the cervical part here, you will see that it's very thin, just about 0.3 to 0.4 millimeter. Moreover, conventional preparation technique often involve deeper reduction. So, this cervical area, we have to reduce it about 0.5 millimeter, which remove a large amount of enamel at that part. And even we follow the minimal preparation guidelines, the approach of prep from the present can sometimes remove more enamel than it is actually needed. This is why we need to focus on preparation. The preparation design can impact the success and longevity of ceramic veneers. And many studies agree on that point. Minimally invasive preparation should stay within the enamel. Exposing dentine can cause several issues. The bond is less reliable than on enamel, which lower the restoration survival rate. And it can also lead to marginal discoloration, interfacial gap, and of course, fractures. So preserving enamel is absolutely critical for long-term success. And research shows that ceramic veneer bonded to dentine or with margin placement in dentine are about 10 times more likely to fail when compared to those bonded totally to enamel. And this clearly highlights the importance of preserving enamel for the preparation margin. So, the question is, how much enamel do we really need for an ideal bond? Research tests veneer preparation with varying percentage of remaining enamel guided by the digital. And the findings indicate that leaving over 40% of enamel is enough to achieve a bond strength similar to that of full enamel coverage. And this study is actually a systematic review and meta-analysis that tracked the survival rate of ceramic veneers for up to 20 years, covering more than 7,700 veneers placed in almost 1,000 patients. This found that the long-term success of ceramic veneers rely on two main factors. The first one is minimally enamel-based preparation, and another one is strong adhesive bond between the ceramic and the tooth structure. So I can confidently say that the success of ceramic veneers relies on preserving enamel to ensure a good retention, long-term durability, and reduce the marginal discoloration, plus optimizing the ceramic thickness to achieve the preferred color, shape, and strength. And if we do it correctly, the outcome should be both beautiful and long-lasting. Moving forward, we now use prep from the future. Instead of following the existing tooth surface, the preparation is guided by the final shape and volume of the veneers. And this approach is applied with the APT, or aesthetic pre-evaluative temporary technique by Dr. Khalid Gurel. With this approach, we can ensure that the veneers sit entirely on enamel, and remarkably, a 12 years follow-up show a 0% failure rate. And to use this technique, we have to start with the design, and either a traditional workshop or a 3D printed model is acceptable. Next, we create a putty index from the design and use it with the Bridge acrylic temporary material to make the intraoral mock-up, like this one. And now, we have the final volume of veneers added on the tooth surface. And then I use the depth cutter burr or depth marker burr, depending on the manufacturer, to create the depth cut on the temporary mock-up. With this movement, as shown on the slide, and we'll get the labial depth cut and incisal depth cut. And we need to mark the depth cut with the pencil before we removing the remaining mock-up. And at this point, we'll notice that the pencil marking indicates the tooth surface that actually need to be ground down. And how can we double check this? We can fabricate the bracket with the putty. The one we'll use for labial depth check and another one we'll use for incisal depth check. But for labial depth check, we need to cut it like a booklet cutting like this. And when we use it, we have to put it like this and flip each part one by one to check the space that we have for the restoration. And for another one, we use it in this way to check the incisal depth that we have cut. And you may ask, can we modify it with digital way? Yes, of course, this is digital era, so we can print from the design. Use the digital design to create a printed depth guide, and this guide should adapt precisely to the printed design model. And we need to use this guide with periodontal probe to measure the labial depth or even an incisal depth. But we need another guide for the cervical area, like this one. The advantage of using this guide is their stability, like Dr. Chachawin said, because they are made from printed plastic, so they stay much more stable than putty. But they come with an extra cost that you have to pay more. And once we have the final impression or digital scan, and we move on to the temporization, this is key for letting the patient get used to the new tooth shape and preview the final smile. I usually add a resin coating to the temporary. It really boosts the aesthetic look, and just like I mentioned in the direct concept veneer section, these materials can also be used successfully for ceramic veneer temporary. And before we jump to the next step, just a quick note about working with the dental lab. Here is a quick tip. After impression or scanning, make sure that you take the abutment shade before temporization. It really makes a big difference in achieving the perfect final color, because the final shade of a veneer is actually combined of three factors: the abutment shade, the resin cement shade, and the ceramic shade itself. So, the more accurate information we record, the more predictable final outcome will be. And when we talk about the color of ceramic veneers, here is a case. The patient had ceramic veneers for over 20 years. He felt that the color had become too yellow for him, and some area was chipped. His goal was to refresh the smile with a brighter and more beautiful color while keeping it completely natural. And here is a closer look at the veneer. Notice the chipped and the marginal discoloration that need to be replaced. And after removing the old veneer, I noticed it was already quite dark, and the veneer is already quite thick. It's about 1.5 millimeters, and the underlying abutment very dark like this. This would make achieving a natural color more challenging. So the question is, what do we do when the patient wants a very white final shade, but the abutment underneath is quite dark? And how can we mask the abutment shade in this situation? Choosing the opaque shade of the resin cement, or should we depend on the opacity of the ceramic itself? And this study observed the color masking ability of different ceramic translucency and resin cement shades. The results show that the change in veneer opacity is actually more effective than the changing the loading agent opacity when it comes to masking dark underlying substrate. And take a look here. When we put veneers on a dark abutment, notice how the abutment color shines through the ceramic veneer, especially for the high translucent ceramic. And this changes how the final restoration looks. So, for the case that there is a dark color in abutment, with the combination of low translucent ceramic and opaque resin cement, we can transform to something that looks natural and beautiful smile. And with the limitation of time, we have here is summary of the information that you need to send to the dental laboratory, even to make it ensure that they can fabricate a beautiful and well-fitting veneers for you. And the next step is materials. The choice of material determines not only the aesthetic outcome, but also the strength, durability, and long-term success of our veneer. And the popular choice is glass ceramic. But there are various kinds of glass ceramic, such as the feldspathic, hillside reinforced, and lithium disilicate ceramic. The most popular material for ceramic veneer today is lithium disilicate and its derivative. They offer excellent aesthetic outcomes with translucent, fluorescent, and opalescent that closely be like a natural tooth, and at the same time they provide strength and toughness, making them reliable enough for even a thin veneer. But in terms of a digital way, you may have a question that can we mill ceramic veneers instead of pressing them? So there is a lot of study. But in the past, some studies show that milled glass ceramic tends to have a poor adaptation and marginal fit when compared with the pressed one. But when we look at the newer study from 2022 to 2024, the story has changed. No significant difference were found between pressed ceramic and milled ceramic in terms of marginal fit and overall property. So it showed that how far our technology has developed. What used to be a limitation has now become a reliable option. And let's review the survival rate of ceramic veneer. Follow over a short term 1 to 3 years, mid-term 4 to 6 years, and long-term more than 7 years, and of course up to 20 years. Across all time frame, lithium disilicate consistently showed the highest survival rate, proving that it has a reliability for a long-lasting restoration. And interestingly, if you look at the number of the veneer included in this study, lithium disilicate stands out as the most popular choice. But we also have another material option, which is zirconia. You might have noticed a trend lately about using zirconia to fabricate the veneers. And zirconia offers the benefits of high strength, but this comes with a compromise in aesthetic outcome due to the absence of the glass base. It is also difficult to etch with the hydrofluoric acid, which can make bonding more challenging compared to the glass ceramic. And when we looked at the survival rate, zirconia show great survival rate in the short term, but we still need more study in the mid-term and long term. So, zirconia may not be my choice for ceramic veneer, but it may be an option. And the last step is cementation. Let me emphasize this again. For ceramic veneers to succeed in the long term, it's not enough to just do a minimal enamel-based preparation, but we also need a strong adhesive bond between the ceramic and the tooth structure. And to achieve that, we have to combine micro-mechanical retention, chemical bonding, and bright resin cement. And with the limited time again, let me quickly wrap up the entire bonding process for lithium disilicate. I'll summarize at here one slide. For micromechanical retention, we start by etching with the 5% HF for 20 seconds, then rinse it off with the air water spray for 1 minute, or even better, use an ultrasonic cleaner with 95% alcohol for 5 minutes to remove those insoluble silica fluoride salt that can otherwise weaken the bond. And next, for the chemical bonding, apply a thin layer of silane and let it sit for about 1 minute to allow proper evaporation and reaction. And finally, for the resin cement, make sure to choose the right one. Preferably a light cure resin cement, since it gives you a better working time. And for the zirconia, thing works a bit differently. We still need micro-mechanical retention and chemical bonding and proper cement, but different method and step. First, use the air particle abrasion with 50 to 60 micron alumina or maybe a silica-coated alumina particle at a pressure below 2 bar. And then specific ceramic primer, especially for the one that contain 10 mdp, and it should be same manufacturer as your resin cement. And finally, choose a dual cure resin cement because zirconia is opaque than glass ceramic. The light might not penetrate enough. And this is the complete pathway to perfection from design to cementation. But please let me wrap up the pathway again by showing you this case. She mentioned about the tooth length and told me that she had a spacing between teeth before. But even after having a composite veneer, she could barely see her teeth when she smiled. And that really impacted her confidence and how she felt about her smile. She also mentioned that the composite veneer on tooth 1, 2 kept shifting. She had it repaired several times already. And for this case, I also used a digital smile design, which allowed me to design directly on the file that merged with the face photo. And this made it much easier to communicate and discuss the treatment plan. So my patient could really understand what her new smile would look like, and also the length or even the labial volume that it adds from the final veneers. And then I print the models and use this to fabricate a putty index for the mock-up and let the patient see how it looked in her mouth. And if she was happy with the result, this mock-up would then be used for the APV technique, and the putty would later serve as a guide for the temporary veneer after preparation. And then I use the depth cutter burr for preparation through the mock-up and mark the depth cut with pencil. Then after taking off the remaining mock-up, you can clearly see that I increased the incisal length for 1 millimeter. There was no need to grind more to structure at this area, but there is still a lot of old composite veneer that I have to remove. And this is when I removed the old composite veneer off. And then in this case, I use a digital scan instead of taking a conventional impression. And the nice thing about this is that I could instantly check my preparation. and the space for the restoration. And if I saw something that didn't look perfect, I could just refine it a little bit and rescan it immediately. And another advantage, we can even capture the abutment shape directly with a digital scanner. For the temporization, I simply use the same putty index from the APT step with resin coating for shiny outcome. And it's quick, efficient, and ensure that the provisional reflects the same shape we agreed at the mock-up step. And I chose lithium disilicate for her ceramic veneers. As I mentioned earlier, it offers excellent aesthetic, high strength, and allows for an effective bond, and all of which are important for long-term durability. And when it comes to cementation, I first try in the veneers using a try-in paste, and this way I can check the final look, including the color, and the patient can also see how it will appear. And once she is satisfied, I go ahead with the resin cement in the same shape. And here is the result 1 week after cementation. Let's look at the before and after photo. You can really see how we were able to transform the patient's smile using the ceramic veneer. And this is wrap up all pathway to perfection for indirect ceramic veneer. So, as a take-home message, the next generation of direct and indirect veneers isn't just about discovering something new, but it's about using what we already know and the tools that we have in a smarter way. And of course, new materials and technologies will keep coming, but they still need time to prove themselves. So let's stay open to innovation, but always remember to understand what we are using and why. And in the end, I hope that you can create your own pathways to perfection, shaped by your experience, your passion, and your way of seeing beauty. And that brings me to the end of what I wanted to share today. And if you like to connect or get to know me a little longer, little better, you can scan this QR code. That's my Instagram. And thank you so much for your time and attention today.
Thank you very much, Dr. Munin, for the excellent and inspiring presentation.
We will now take questions from the audience. Are there any questions?
Firstly, thank you, Doctor, for the perfect presentations.
Thank you.
The question is, in cases where the teeth are slightly cornered and the prominent area of the natural teeth interfere the mocked-up materials, should we reshape the tooth before the mock-up preparation, or there is any recommendations in these situations?
Yes, in that case, there is subtractive area that we need to grind it down before we use the mock-up. So we need to tell the laboratory to make the 3D model print another one, that the final one without the old tooth shape, and another one with the old tooth shape. And you have to make the putty index from both models, and then you have a guide for your preparation.
Thank you for your answer.
Are there any more questions?
Hi, I'm a student of prosthodontics from PSU. I have a question. From your last case of the presentation, after you preparation through the mock-up of the BCA cream mock-up, I see that even with the reduction of the mock-up, you still have a remaining tooth structure. So after that, after the preparation, do you still have to do the margin if there is enough space for the veneers?
Of course, we have the space before all of, I think most of my ceramic veneer case, I do the additive design. So I add the amount of the labial volume for the final veneer, more labial, about 0.3 millimeters. But the depth cut burr should be 0.3 or 0.5 millimeters. So whatever you prep, you always have a space for the restoration.
So you mean after removing all the base air group,
Mhm.
we will still have to do the margin?
Yeah, we still have to do.
And other than the margin, at the center of the preparation side, I mean the whole labial side, you still have to need more reduction.
Okay, I misunderstanding. And in that case, if there is no composite, my case has the composite veneers, so I have to remove. But in the case that is natural to structure, you don't need to remove the labial side. If there is no pencil mark, you remove just the area that indicated with the pencil mark, and of course for the cervical margin, that's all.
Okay, so in wrap up, so after removing all, you will just only grinding for the pencil mark to be reduced,
Yes.
and more of the margin, but not the center of the tooth. This is right.
Of course.
Thank you so much.
Thank you for those excellent questions. May we now invite Associate Professor Chakri Ongthiamsak, Vice Dean of the Faculty of Dentistry, Prince of Songkhla University, to give certificate to Dr. Munin Chaichanutham.